Hello friends, today we'll be discussing about hematuria and approach towards the patient and some management of hematuria. So first of all, if we have a patient of hematuria, how will we assess the patient? So starting with the age of the patient, if the age is more than 35, then it is a risk factor for malignancy. So we have to consider the age. Then sex, male sex is a risk factor as compared to females. So we have to consider that. Smoking is a risk factor, so we have to consider that. Then whether there is pain in the abdomen, in the flank, or in the suprapubic region, that pain is radiating to the groin, that we have to consider because that can give us a etiology of either renal stone disease or cystitis, infective etiology. Then timing of the hematuria, that is, it is throughout the uh, throughout urination, that could be due to upper urinary tract from the kidney or the bladder, or it is initial, that could be from the urethra, or it is terminal, that is through the bladder, neck, or prostate. Then whether there is presence of fever, this could be another history that could give us a chance of reason of infection. Apart from that, there are some other historical findings like any exposure to chemicals, any history of previous urological disorder, history of catheterization or trauma, history of chronic catheterization, and history of pelvic irradiation, etc. Then coming to the clinical examination, we'll assess for any tenderness in the flank or in the suprapubic region or any renal angle tenderness. It is very important to check for the genitalia for any injury or tenderness, and if the patient is of adult more than 40, then we should also assess for prostate. Then after history and examination, we will check for the lab investigation, that is the initial investigation where we'll go for urinary examination. So urinary, it has to be collected ideally in the morning, but it should be not the first urine specimen after recumbency. Also, it should not be after vigorous exercise or intercourse because that alters the result. As the RBCs are lysed in that, the chances of incorrect result is more. So we'll check for RBCs in the urinary examination. So it could be into three levels. If it is more than 3, that is 3 to 10, then we call it as at more than 3 is microhematuria. Then we have 10 to 25 and more than 25. So this is mild, moderate, severe. Then we can see for malignant cells, that is NMP22 and bladder tumor antigens. Then pus cells or WBC, which will be giving us the picture of UTI, and so we should give it for culture sensitivity. Then CAS or dysmorphic RBC, that will give us a picture of glomerular or tubular hematuria, and it will be cola colored. Along with that, there could be proteinuria, which can be again in the form of glomerular cast, and it is seen when it will be more than 2 plus protein or 3 gram per day protein. Then we'll check the HP for the severity of hematuria and whether we need to give blood transfusion for improvement. Nextly, we go for KFT, that is, we check for any acute kidney injury or known chronic kidney disease that could affect the kidney function test and cause raise in creatinine, which has to be optimized before any contrast used imaging like contrast enhanced CT scan, and also before procedure. Then sodium, potassium, and ABG for any metabolic derangement, which has to be corrected before any procedure or higher investigation. Then we come to imaging. That is first line which we go for, that is ultrasound, KUBP, urinary bladder and prostate, kidney, ureter, bladder and prostate, along with PVRV, that is pre-void residual volume. And this will give us a rough estimate of any hydronephrosis, any SOL, or sometimes stones, sometimes cystitis, prostate enlargement, or residual urine. And if we have strong suspicion of any pathology which needs CT evaluation, we can omit USG and we can directly go for CT Euro, that is contrast enhanced CT scan, that is CT Euro, which is the investigation of choice. It also gives us contrast excretion from the kidney, which is helpful for evaluating collecting system lesion, and it has high sensitivity. And if contrast enhanced CT scan is contraindicated, then we go for MR Euro or NCCT uh, Euro along with retrograde pyelogram. And if we get a lesion in any of these, then depending on whether it's a gynecological issue, medical issue, we either refer or take a joint decision. If it's a surgical issue, then we handle it in the surgical care. If in CT or MRI we do not get any lesion, that is, it is negative, then we go ahead with cystoscopic examination. So in cystoscopic examination, as per the American Urological Association, if we have negative finding in the imaging, we go for cystoscopy with hematuria. And apart from that, cystoscopy with hematuria with age more than 35 years with any of the risk factors, then we should go for cystoscopy. So cystoscopy is the only test for carcinoma in situ and small lesions of the bladder. So it has to be done. And bloody efflux from the ureteric orifice, which will help us lateralize the pathology over the side of ureter and kidney. And we can also take biopsy and go for TURBT for small lesions of the bladder tumor. So now, considering there are 12 risk factors for hematuria as per the American Association of Urology, that is, first one is the male gender, then age more than 35 years of age group, then smoking, then occupation, involvement of dyes and chemicals like the benzene and the aromatic amines, analgesic abuse, gross hematuria, history of previous urologic disease, history of irritative symptoms of the LUTS, lower urinary tract symptoms like frequency, urgency, then pelvic radiation for any tumor or any pathology, exposure to chemotherapy, especially the alkylating agent, then chronic UTI and chronic indwelling foreign body. Now we see the risk stratification for hematuria patient, that is divided into three, that is low risk, intermediate risk and high risk. It will help us in further evaluating these patients more easily. So if female is less than 50 and male is less than 40, they have never smoked or history of less than 10 pack years of smoking, 3 to 10 RBC, no added risk and no previous hematuria, microscopic hematuria, then it is low risk. Then intermediate risk, and in low risk we generally go for urinary and ultrasound examination, and if needed cystoscopy. In intermediate risk, when the age of male and female is less than 59 years, smoking is 10 to 30 pack years, and we have 11 to 25 RBC per high power field. Dr. Padmaja Reddy case surgery atheist pound. Then if any of more than one risk factor is present and previously no risk or no prior evaluation, and 3 to 25 RBC per high power field on repeated urine examination. This all comes in intermediate risk. So here we'll go for ultrasound and cystoscopy as per the need. Then coming 3, in high, when the age is more than 60 in both the sex, more than 30 pack years of smoking, more than 25 high power field, history of gross hematuria, and previously low risk, no prior evaluation, and more than 25 RBC per high power field. So all these will come under high risk for hematuria, high risk hematuria, and we have to consider CT Uro and cystoscopy as per need for further evaluation and management. Then coming to management of some surgical causes in case of hematuria. Apart from that, for stabilizing the patient with hematuria, if there is some obstruction, then we have to catheterize and decompress the urinary bladder so that there is no further collection of urine and obstruction causing obstructive uropathy. And if required, we have to use three-way catheters and provide irrigation so that hematuria does not cause further blockage of catheter. So until the patient is corrected definitively, we may have to give irrigation. Then coming to surgical management of some of the disorders, that is, if there is a stone, then we go for before going in the management, let us discuss some of the common causes of hematuria. That is, we can divide it into very commonly the infection, which could be of anywhere in the urinary tract, starting from the kidney or the ureter or bladder, prostate, urethra. So any of these organs in the order can be involved in infection. Also, there could be some tumor in any of these, could be benign, could be malignant sometimes. Thirdly, there could be stone disease, renal stone disease. Fourthly, there could be a arteriovenous malformation in the kidney especially. Then there could be history of some renal vein thrombosis that could give rise to hematuria, which is though a rare cause. And lastly, there could be trauma in any of these areas can cause hematuria. Other medical causes and some gynecological causes also have to be considered. Medical causes in the form of glomerulonephritis, IgA nephropathy, and in gynecological causes we have to consider for endometriosis of urinary bladder. Then coming to the surgical management of some of these common disease, for renal stone we go for URS and DJ stenting when it is involved in the ureter. Then ESWL, that is shock wave lithotripsy. Then PCNL, percutaneous nephrolithotomy. Then open lap robotic pyelolithotomy. Cystolithopaxy, that could be open or cystoscopic. For SOL in kidney, we can go for open lap or robotic partial or total nephrectomy, ablation through cryo or radiofrequency ablation, chemo or immuno-targeted or radiotherapy. Hello, sorry for the disturbance. Then angioembolization of SOL before partial nephrectomy or palliation therapy. In recent advances, enucleation of the SOL or off clamp partial nephrectomy, which is through robotic. Then SOL in bladder, where we can go for TURBT or biopsy. if needed, lap open or robotic cystectomy, which could be partial or radical with neobladder formation and diversion. Then intravesical immunotherapy in the form of BCG and mitomycin C, chemo and radio for muscle invasion. Then coming to prostate, that could be due to infection or malignancy in the prostate, giving rise to hematuria. Here we go for truss guided biopsy, followed by in surveillance or intervention. If we have to go for intervention, we go for either URP for bladder outlet obstruction or radical prostatectomy, that is robotic mainly nowadays, or open depending on the scenario, orchidectomy if required, androgen deprivation therapy, chemo or radio as per need. For pelviureteric junction obstruction, we go for lap open or robotic pyeloplasty. For arteriovenous malformation, we go for angioembolization. Or we can go for open, lap or robotic, partial or total nephrectomy. So these are some of the common causes of hematuria and their management. So hope it has been understood and will be helpful for quick revision and useful for writing exam on the topic of hematuria, approach and management. So thank you for watching. Please like, share and subscribe. And the link for the notes is given in the description below, which is available on my Telegram channel. And the link for the Telegram channel is also given in the description below. So keep studying, keep growing, because knowledge is power. Never give up, because great things take time. And please like, share and subscribe if you have liked the video. And see you soon in next video. Thank you.